Okay, well, 6 o'clock. Since everybody's here, let's go ahead and get started. We'll call this meeting to order. If you join me in the Pledge of Allegiance, please stand. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Just for all.
Thank you very much. Dee, can you please call the roll?
Yes, Director Yee,
Present.
Director Stewart,
Present.
Director Wallace,
Present.
Director Eapen,
Present.
Director Nicholson.
Present.
Very good. Very good. Well, welcome to the January 12th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from dangers posed by the SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3 BII of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Thank you. Is there a second?
Second.
Thank you, Mr. Wallace. Dee, can you call the roll, please?
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eapen,
Aye.
Director Nicholson.
Aye.
Very good. That motion passes. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom, and I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting, and it will be posted on our website for future viewing. Okay, let's move on to communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at the meeting? No? Are there any written communications, Dee?
No, there are not.
Okay, thank you. Well, moving on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve the consent calendar item A?
Madam President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar item A.
Very good. Is there a second?
Second.
Thank you, Dr. Stewart. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen,
Aye.
Director Nicholson.
Aye.
Very good. That motion passes. Thank you very much. All right, let's move on to our reports. First up is the medical staff report by the Chief of Medical Staff, Dr. Hyder. Happy New Year,
Hi.
Dr. Hyder.
Happy New Year. Good evening to all. Then the numbers by medical staff category for January 2022 is active number is 348 with allied health 34, ambulatory is 89, consulting is 8, courtesy is 25, and provisional was 60, total of 564. Yesterday we had a general staff meeting and it was well attended. In that, I made an announcement that with a lot of sadness and condolences, Dr. Burke passed away on December 27. He used to be Washington Hospital. He worked as a cardiologist as well as for Sutter Healthcare too. And the other thing is COVID booster is mandatory by February 1, 2022, and all providers must send booster information to the medical staff office if they have not. This was told to the medical staff. And we will not be practicing at Washington Hospital if we do not provide proof of vaccination booster after February 1st, 2022. The twice weekly COVID testing is required starting January 17th, if not boosted. And the doctor's lounge will be open by the end of February. We are waiting for the ASH part to give a clearance. And the work has been done excellently, the furniture, everything. And we're just waiting for that, and it will be open at that time by the end of February. And this is my report.
Very good. Thank you very much. Thank you.
Thank you.
All right, Service League report. Debbie and Sheila are both here. We are glad to see you ladies.
Thank you. Good evening from the Volunteer Service League and the volunteers, and Happy New Year. The month of December capped a busy year for the volunteers. For the Service League, 119 volunteers contributed 1,473 hours for last year. Our baby cuddlers really stepped up after a baby born on Christmas Day, needed some TLC over an extended period of time, and cuddlers had been keeping the baby comfortable for over 2 weeks. And I heard he was discharged on Tuesday. So that's good news. The volunteers were also busier than ever doing syringes for the COVID-19 vaccine, and the demand for vaccinations clearly went up in December and now. And we've assembled 157 kits in December. In November, it was 157 kits. In December, the total was 1,467 syringes. So it went up like ridiculously from 1 month to the next. And since the volunteers began assisting the pharmacy in early 2021, we've assembled over 37,000 syringes. So labeled over 37,000 syringes. On the behalf of the Service League, I would sincerely like to express my appreciation to board member Jeannie Yee and Sheila Vijay for leading the charge on this. Also, in the past 12 months, we have assembled 22,300 COVID test kits used throughout the facility, and my thanks go to Ruth McGutha for her leadership on this. And looking ahead to the new year, we'll be holding our annual meeting in late February, where the new board members will be voted into office by the membership. And I want to thank you all for the support that you've given us, and look forward to another year. And that's the end of my report.
Thank you very much. Thank you. It's great to be back in service after having all those months off and feel like we can make a contribution. Thank you. All right, for our quality report, Kimberly, do you want to introduce our presenters?
Yes, thank you. And I just do want to echo in terms of what Debbie said. I mean, really, the Service League has made a huge impact. As you know, vaccination and COVID testing are two really important pieces of fighting the COVID pandemic, and you've really helped us to be successful at both. So thank you so much, and thanks to all the Service League that have played such an important role in this challenging times that we've had, but you've been part of our success. So thank you so much. All right, I do want to introduce, as we know, Mary Boron, who's the Chief of Quality and Resource Management, is here this evening with Dr. Diane Martin to present the Infection Prevention Program for 2022. And I just want to, I know Dr. Martin is familiar with most all of us, but I do want to just give a little bit of background on Dr. Martin. She's been a member of our medical staff since 1984. She has served in many leadership roles at Washington, including the chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection control. Dr. Martin has been a physician champion for our 5 Million Lives campaign, where she analyzed data and educated her peers on infection control issues. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine, and she serves on the board of directors of Life Elder Care, and she is a member of Washington Township Medical Foundation. I also do want to just thank Dr. Martin. She is another one that has been instrumental in helping us through the challenges of the pandemic. And I know that we're not through them yet, but she has really been in terms of our leading expert on infectious disease issues. And she's partnered with Mary in many ways, but she has been there basically 24/7 for many of us in terms of when we needed some guidance around COVID-related issues. So she has really helped us to successfully navigate the challenges we have faced. So I do thank you very much, Dr. Martin, for all that you've done to help us up to this point through this pandemic. All right, Mary and Dr. Martin, I'll turn it over to you.
Okay. So Mary and I want to present the infection prevention program. I'm going to do part, and then Mary will also talk to parts of it as well. So can we have the next slide, please? So the background is that we look at healthcare related infections, and it's chartered by the CDC, and we look at about 1.7 million per year, which is, you can see it quite a lot. And estimated 240,000 patients are admitted to California hospitals annually due to developing hospital-acquired infections. So we take this very seriously and try to see what we can do to try to improve this, both for our facility as well as the health of our patients, and also extending to their families. Healthcare-associated infections are among the top 10 leading causes of death in the United States. And these can be prevented. Close monitoring, education, which we will touch on in a bit, awareness and consistent application of evidence-based practice to ensure patient safety. Washington Hospital has infection prevention program that is hospital-wide, multidisciplinary, including pharmacy, nursing, environmental services, IT, all of them come together to support this effort. And with that, we think we can effectively prevent, identify, and control the spread of these infections. Next slide. So as Ms. Hartz noted originally this started out as a campaign in 2006 for the 5 million lives, which was mostly centered around staph infections. And we have increased that dramatically over the last several years. And the National Healthcare Safety Network, or NHSN, which is part of CDC, started requiring that we reported these in 2009. Our program works 24/7 to prevent and eliminate infections. And it's, again, multidisciplinary and involves many aspects of the hospital. So we include surveillance of hospital environment, real-time reporting and analysis. We have excellent, thank you to the board, software to help us maintain some of this monitoring in terms of very complex data, because all of this has to be reported to the NSHN on a very regular basis. We also go over hospital acquired infection reports on a day-to-day, quarterly, and yearly assessment, and you'll see some of that later on in this. We're very fortunate to have excellent teamwork between the nursing and then also Joyce Roberson, who was one of our hands-on IP coordinators, who then went to work remotely and recently retired, but she really championed this and made it a real-time project for all of us to work on and work through. So this is a multidisciplinary group. It has myself in it, the Chief of Quality and Resource Management with Mary Bowrun. We have an infection program prevention manager, Gulnaz Hadif, who has been with us in the last year and is outstanding in working through some of the NSHN's data. We have an infection preventionist who focuses on education, Diana DeMarta, who also works tirelessly answering questions for the nurses, the pharmacists, and the patients alike. We have weekend coverage by Laura Tang, and she does a lot of our surgical site infections. And then we have all of the other departments working in conjunction with us as well. Nursing, quality resource, compliance, and patient safety. Many physicians are champions for us behind the scenes, central processing, environmental services, nutritional services, which is very important, pharmacy, laboratory, OR, cath labs, and also medical imaging. Next slide. So key components of our program include quality and patient safety, and this is in part through our infection prevention committee, but also multidisciplinary and microbial stewardship committee. We also work with employee health, and they work in conjunction in helping us coordinate some of our education and also information towards the nurses and other staff members. We look at transmission-based precautions, specifically hand hygiene. We look at risk assessment for construction, and Mary will touch on that a bit later. We look at outbreak management, i.e. what we're doing today, and public reporting, as well as our COVID response planning, which is changing on week-to-week basis. I've never seen something quite like this in my last 35 years of working in infectious disease. We do active surveillance for root cause analysis, where we're seeing surgical site infections. We look to see if there are patterns. Is there an OR area that we need to look at? Is there pre-operative antibiotic uses that we're looking at? Is there particular cleaning that we're looking at in terms of the prep, the surgical prep for the patient? So multiple ways of looking at this. Also hospital-acquired infections. We look at isolation. We look at trending. There are some multi-resistant bacteria that we are very concerned about looking at. We have had very few of that in our hospital, and they're mostly from patients who are at outside facilities that are coming into our facility. So we have not seen transmission within our facility, but we are very on top of watching that specifically because this is very serious for patients as well as for staff. We do education on a very regular basis between staff and also providing updated patient education, including right now the SARS education, and we'll touch on that in a bit. We're also looking at evidence-based policies and procedures, how we might look at cleaning and disinfecting, sterilization of our devices and equipment, and the cleaning area also looks at different ways that we can improve on this. They're constantly bringing up new ideas and ways that we can improve. Hand hygiene compliance, we work on very diligently. We have some months that are much better than others, but we are trying to champion as many people as we can to be as consistent as they can, because if we wash our hands, we can prevent infections, and that's what we're here for. We are again looking at a management of multi-drug resistant organisms. We're doing oversight with other departments, such as food, nutrition services, laundry. We're also working with employee health for education, orientation, and training for new hires in all the disciplines, and to provide updated information where needed. Next slide. So Washington Hospital looks at data reporting, and again, the NSHN is our primary one for looking for hospital-acquired infections. We also work through CDC, Medicare and Medicaid, California Public Health Department, as well as Alameda County Public Health, and especially in terms of communication between communicable diseases, but also any of our drug resistance. Next slide. So the COVID prevention and control measures that we're doing for 2022, this is an evolving process that's started in the last 2 years. We're working on it, trying to keep updated as best as we can. We are screening for symptoms of COVID prior to and arrival on the facility for all of our patients and visitors. We're doing immediate isolation if we think the patient's symptomatic or high risk. We require universal masking, including our patients. So the patients have masks distributed to them every morning. If they fall on the floor, we give them another one, but as long as somebody else is in the room with them, they're required to keep the mask on just like we are. We have updated the safe visitor restricted policy over time. That gets a little bit more restrictive given the situation going on now in terms of screening for the visitors, but also we try to make it more patient friendly in terms of patients who have cognitive issues, translation issues, and also end of life issues. So we're trying to be as flexible as possible, but safe at the same time for our staff as well as our patients. We do mandatory COVID testing for all surgeries. Elective are restricted during our COVID surges. We had that probably in the late summer, where we just basically said the risk is much too high. We'll restrict the elective surgeries, proceed with those that are urgent, and continue to monitor. And again, all of our admitted patients are tested for COVID. And it's initially was not a surprise when you saw a patient, but I have to say lately we have been surprised where a patient was coming in for, say, a hip fracture or a syncopal episode, and they're testing COVID positive. The ER is very good about making sure that all patients are masked. So we're not surprised in terms of we might have been exposed, but we're somewhat surprised in that, this is a COVID patient that we didn't expect. So we are very cautious with all of our patients from door to door. Next slide. So in terms of COVID prevention and control measures, what we are looking at is we have, obviously, there's been in the news, more of what we're seeing is Omicron. So we have COVID response meetings looking at this. We're also ensuring supply chain, which has been quite a challenge, but I have to say our facilities management has been very good about providing our staff with a proper PPE. If we don't have it, they go find it. And it's just amazing what they have been able to come up with, because a lot of times everybody else is clamoring for the same PPE, and our hospitals managed to provide for us. I know other hospitals don't have quite the backup that we have had, and I'm not sure how much that gets communicated to the board, but your administrative staff has done a fabulous job in terms of making sure that our staff are safe and protected. So we're doing more increased surface decontamination, environmental cleaning throughout the hospital, whether it's the cafeteria or the lab or the rooms, they are cleaning very diligently. We're again maintaining a consistent supply of personal protective equipment. We're communicating with the local skilled nursing facilities. They have had surges, and we like to stay in touch with them to make sure that we can provide for them. I mean, many of them are corporate organized, but many times they are not always getting the supplies that they need. So the hospital has been able to reach out to them where they needed a temporary supply of masks, a temporary supply of gowns, gloves. It was much worse early on. The SNFs are doing much better. We also work very closely with Alameda County Public Health. We want to ensure that we are adhering to all of the respiratory hygiene, cough etiquette, and hand hygiene. So Diana and her team go through on the floors, mostly daytime, but it's also sometimes Laura goes on Saturdays and evenings, just to educate and remind and stress how important this is to all the nurses as well as physicians and other staff. We try to encourage physical distancing measures as much as possible, separation of at least 6 feet between patients while they're waiting. And you'll see that if you're coming in through the front door, visitors are coming in to be evaluated, patients coming in, they're also social distancing. We are following national standards for healthcare worker safety, and we have also increased the number of HEPA filters throughout the hospital to make sure that we can accommodate any of the surges that we're going to see, because anytime we have a patient that's either COVID suspect, they are in a negative air pressure flow room, which is the HEPA filter unit. Next slide. We're doing COVID vaccine planning right now. You'll be very amazed at your staff, 98% fully vaccinated, which is an amazing number. We have 2% that have exemptions, and those are tested twice weekly. And as mentioned earlier, the healthcare workers are required to be boosted by February 1. We have a community vaccine clinic that's going out at the 2500 building, which goes from 8:30 to 5 Monday through Friday. Those are pretty much by appointment only. So again, we try to maintain our social distancing. Next slide. So in terms of education that we provide to patients, whether they're patients who are admitted or patients seen in the emergency room, we give them information what to do while they're waiting for their test results, because sometimes patients are tested, and if they don't look like they're going to need to be admitted, they're discharged home and then called back for their test results. We talk about home quarantine and isolation, what the test results mean to the patient, and when to get more urgent, emergent medical care. For those patients who test positive, we again stress home isolation, how to manage their symptoms at home, how to protect others in their home, because many times we see large families that are in a single unit. We talk about infection prevention measures that can be done at home, and of course, when it's safe to stop the isolation. We use several education resources, CDC, Alameda County Public Health, and then also a We Educate education resource. And these are provided at the back of the patient's what we call after visit summary, whether the patient's being discharged or they're going home from emergency room. Those are after visit summaries that are printed up and include all of this. If the patients are on the MyChart, which we strongly encourage, then we generally don't print unless there's a language problem, just because we think that we want to encourage them to use the MyChart so they can look for their test results, they can get updated on anything that's changing, and obviously to get as much resource information. And then it's right at their fingertips, where they have it on their iPad or their Apple Watch or whatever. Okay, next slide. So I think this is where Mary's going to take over, because she knows more about this than me.
I don't know about that, but thank you, Dr. Martin. Yeah, so in an effort to keep patients and healthcare workers safe, there are quite a few regulations actually around infection prevention, and those are monitored on a federal level, on a state level, and a local jurisdiction level. And the main body that oversees this is the Joint Commission, and they also monitor closely for CMS and while they're here doing their surveys. They do this in the form of expecting us to meet some goals around national patient safety goals. And we actually have a dedicated chapter in the Joint Commission book for goal number 7, which is dedicated to really the infection prevention program. So without getting into too much of the details of it, they essentially have requirements around making sure that we have a well-established program, which is what we're here talking to you about this evening, and that we're complying with standards around hand hygiene, making sure that we're looking at evidence-based practice to prevent healthcare-associated infections, especially ones that are device-related with our central lines, our catheters, all those they look at very closely to make sure that we do bundle practices that improve patient outcomes and decrease the risk to developing a healthcare associated infection. They also look closely at our surgical site infections to make sure that have all practices and meet standards of care in our OR settings that will prevent patients from getting a surgical site infections. This is also done on the state level. In California, there are over 30 required procedures that we monitor to closely and see if the patient is showing any signs or symptoms of developing a surgical site infection. This ranges from looking at how closely we take care of room turnovers, the environment, antibiotic care for the patient, education, etc. And lastly, there have been obviously new regulations around COVID, and literally every day in the hospital, we have to report the number of COVID patients we have, the number of patients that are in our rooms with COVID and who we think may have COVID. And in addition to that, our level of staffing and resource and PPE, all of that is reported out, and it's mandatory, and it goes on a local level with the cases, and then on a state level, and then they report it on a federal level to us. So most of the data that you see out there with COVID is coming from following that track of COVID data reporting. Also, one of the things that is required in any standard infection prevention program is doing an annual risk assessment. And so we do our risk assessment here every year in December. We take all of the data from the calendar year and associated with infection control, and we put it into a standardized infection control risk assessment. And this risk assessment, that is what the image is there, that you can't really see it, but it's just meant to show you that the format that we use. We list out all of the things that we're interested in doing surveillance on and monitoring for the year. And we look back at the year and look at our data to determine what are some areas that we think we have concerns about, what are some areas we can make improvements, where's the heightened awareness, what should we focus on in the upcoming year. So we do this in December with a great deal of help from Dr. Martin and the infection control team, administration, and medical staff really throughout the year help us collect data that we put into this template. And one of the things that we learned, for example, in December of this year of 2021 was we had actually shown quite a bit of improvement in C. diff. And this has always been something that has been the first level of focus for us. We had some issues with having higher than expected C. diff levels. And after a couple of years of making this a top priority, we actually this year when we did our risk assessment, it came down to a lower level of probability and concern, which is good. And so therefore, when we identified our goals for what we want to work on in 2022, we were able to have take areas of improvement to a lower level. We're going to still sustain and watch the things we do to prevent C. diff and catheter-associated infections, et cetera, but we'll have other top priorities. And obviously for this year coming up, COVID response planning is going to continue to be our #1 response that we need to be focusing on. Hand hygiene is another one that we will always have as a top priority because it is the best way to prevent the spread of infections, and it will continue to monitor our device-associated infections, et cetera. This is just to give you an example of sort of how we determine our goals and our priorities for the year of 2022. So we take those goals and we try to come up with what's the best strategic approach to how we're going to look into these and make sure that we reach the outcomes and goals we want to. And this slide is obviously has a lot of information on it, but to focus on some of the strategic approach for this year, again, we'll be continuing to look at reducing risk of SSIs, especially with colons and shoulders, because we've increased our volume there. So we want to really make sure that we're having good outcomes and we're preventing surgical site infections. We have a great joint replacement program, very, very low to almost non-existent surgical site infection rate. Because the volume is so high, we continue to observe that. And the other ones I had mentioned in the prior slide, but in addition to that, we also really focus on the environment and what is the approach we're going to take to make sure we're monitoring the environment and keeping it safe and clean. And really what we do when we come up with this strategic approach is we look at what part of the team is going to be assigned to certain areas of the hospital and monitoring it. And from monitoring your data behind your computer all the way out to walking and throughout the hospital and looking in the environment for things that need to have attention with cleaning or making sure that they're clean, and also keeping our staff and our patients educated. And one of the great ways that we've been able to keep up with everything in the program is, again, as Dr. Martin mentioned earlier, this great EPIC surveillance we have. So our EMR program is very well developed and robust. And so we are able to identify a lot of data coming from our patients and see if they're having any issues with hospital-associated infections, and to monitor the data on the ones that are at risk for getting a hospital-associated infection, but in fact are having great outcomes, such as the SSIs that I was mentioning. So that's also a very important strategic approach we'll continue to follow through 2022. Next slide. So surveillance is something that we have to continue to do, as I mentioned, to make sure that patients are having good outcomes and that they are safe. Most of there are surveillance areas I've mentioned, but just to go over a couple additional ones, especially in the time of COVID, we're really focusing in 2022 on preventing ventilator-associated infections. We have patients, obviously, that are sicker with pneumonia related to COVID. And we recognize that that's a group of patient population that we really need to look at closely this year. And if they are developing any further infections while on the ventilator, that is something we monitor for every single day. And we actually are dedicating a team this year to it. It's a multidisciplinary team that will be watching the outcomes on the patients that are ventilated. It's not just COVID patients, but of course that will be a focus area for us this year. Next slide. Another thing that the infection prevention program works on really closely is monitoring of construction projects. And when you think about construction, you don't initially think about infection prevention, but it's interesting to note that it's actually a really important part of preparing to do any sort of a construction project. So infection control is notified by anybody who is doing any level of a project, even replacing a ceiling tile on a patient unit. Infection prevention would be notified, and our team goes up, a member of our team goes up to the area, and they identify the level of risk. Is breaking down a wall or a ceiling tile going to expose patients or healthcare workers to certain aerosols? And if so, then that is ranked at a certain level of risk that requires a certain level of prevention. So if we're taking down a wall, then infection control will go up and determine what barriers need to be in place. Do we need to use HEPA filters, that sort of thing. So what's great about this risk classification is it keeps the healthcare worker and the patient safe and allows us to keep the building up and be doing projects while we're providing patient care. Water management is another key area of the program. Obviously, our water is used for multiple things, but of course, first and foremost, just thinking in terms of the fact that our patients and healthcare workers and team members obviously can drink the water, et cetera. So it's really important, and it's required on a federal level that we have an actual water management program, and that's been required since 2018. We actually had a program established prior to that, and we've always monitored our water management, but this enabled us to come up with a really robust written program in which we monitored the temperature, of course, of water, because at certain temperatures, water can grow certain pathogens, and that would be a risk. So we want to make sure that we keep the temperatures within a limit that we won't be growing pathogens. In addition to that, we test all of the water on a regular basis, and those water reports are sent to infection control, and there's a standard approach to how we do that, and we follow a protocol. In order to do this, we really have to have a good working relationship with facilities and the management team in engineering and facilities working closely with infection control. Communication is really important about what's going on, and if there are any issues that come up with that, that team really gets together and works with that. But again, we look at these on at least a monthly basis. They're reported through the committee, and we haven't had any issues with that. And as you increase your square footage or you have a new building, we have to continue to monitor in those areas, and we've been doing that since the Morris Hyman Pavilion opened up also in that area. So also environment of care, which I've touched on a little bit so far, is really, really an important part of the program. An environment of care really essentially means rounding, looking at the environment for making sure that things are intact, even looking at what's going on with your equipment in the hospital, gurneys, to making sure that they don't have any cracks in the bed and that things are smooth and easily wipeable, all the way down to watching the floors. So we watch everything from the ceiling to the ground during environmental care rounds. These are done frequently, typically by an infection preventionist. They work closely with EVS to make sure that we're all on the same page with what the expectations are and the standards. We have a very strong EVS team here. They have a dedicated person that helps with education, and they're all very interested and work really well with the infection prevention team to make sure that we keep our environment clean. In addition to that, there are strict protocols that are followed right down to how you mix your or get your disinfectants and how we use those. Everybody has education on those and the purpose of them. And I think you can really see that when Joint Commission comes in here, one of the things that they typically compliment is in our main hospital building, which is obviously quite a bit older than the new building, how great it looks inside and how clean it is. And so I think we're doing a great job there with that part of our program. Again, this is a really important part. It's very important how even a room is cleaned when a patient leaves before another patient comes in. What the EVS team does there is absolutely a core part of keeping our patients safe. So it's great to have a team that is as strong as that, working so closely with infection control. And speaking of expert level, Dr. Martin definitely knows antimicrobial stewardship much better than I do and has led the program here for quite a while, which we appreciate. So she'll be taking on this part of the presentation.
So antimicrobial stewardship originally came about when we were looking at multi-resistant staph aureus in terms of different antibiotics that we needed to monitor to make sure our patients and our hospital staff were safe. So this is what started our antimicrobial stewardship team, because like any other limited resource, antibiotics are very limited. In terms of new ones, there have been very few that have come out. Most of the quote unquote new ones we're seeing now are just combinations of one or more of older ones put together to make a new one. So very few that are actually new. So this team is again multidisciplinary. We have nursing, we have pharmacy, we have IT, we have the ID docs, we have the pathology lab that work together with this. The pharmacists obviously look at and evaluate and streamline our antibiotic regimens to make sure we are using the right drug, the right dose, for the right reason, for the right patient. So we are making sure that we are as safe as possible all across the board. We also want to make sure that we use these drugs appropriately, because if we're using the drugs that we need for the highly resistant bacteria and using them when it's not really necessary, you potentially then will have the bacteria become resistant to those drugs. And when you truly need it, it won't be available. So we go over using guidelines that we kind of agree on, and then we try to educate pharmacy, nursing, and the other physicians outside the ID docs. And again, the C. diff, as Mary mentioned, so C. diff is CDI screening. We did a new algorithm, and that's one of the things that our prior Joe IP worked on, as well as Joyce, to try to improve this. So we did a different way of testing and looking at it to make sure that we are identifying patients who are colonized, who carry C. diff, just like many people carry MRSA on your skin, but we're not truly infected, versus ones who were infected do need to be treated specifically and isolated specifically. So that helped quite a bit, and that the nurses were very receptive to the education that we presented. And then we also presented that information to different committees as well as to the physicians. So this has had support for our hospital-acquired infections through the physician engagement, try to get it to use the antibiotics properly. We also do one where we switch from IV to PO, because that again saves that particular antibiotic that you need for later on. And so switching it from IV to PO makes it much more specific for the patient, specific for the infection, and makes it more user-friendly for the patient. Hopefully, if they're not on IVs, they can then look forward to going home. We have a dedicated pharmacist consultant who's Lena Wong, who has been overwhelmingly dedicated to this program. She does do diabetes on the sideline, but she is primarily one of our champions for the antimicrobial stewardship and has put in very long hours redoing, and with the COVID, redoing again all of our protocols. And so she is a tremendous asset to our program. Next slide. So one of the bacteria that we look at is tuberculosis, which is a preventable communicable disease that's caused by a bacteria, primarily attacks lungs, but can attack other parts of the body, such as kidneys, spine, or brain. 100% of the hospital employees, staff, and physicians are required to have annual TB screening. We work with Alameda County to monitor or survey our incidents. It's interesting that when you look at Alameda County, our Tri-City area, our hospital township district was the highest in our county. You would have thought high density populations such as Oakland or something would be higher. It's not. We see a lot more here because of the diversity of our population and the fair amount of travel of people coming back and forth that either come through the Silicon Valley area, but then maybe visit family here. So we see a lot of this. And we have been very consistent about trying to improve on this. Our TB rate has gone down quite a bit. So the nurse is empowered to initiate airborne isolation anytime he or she suspects a patient. It used to be you have to call this person and that person, and it took a long time, and then maybe it didn't happen. But now the nurses, anytime they suspect this, they put the patients in isolation, contacts the physicians, and starts the protocol. We also do continuous negative pressure monitoring in these isolation rooms. Diagnosis is made after the MD consult, whether it's an ID doc or one of the primary cares, and also working with our laboratory. The county is then notified by infection prevention, and these are carefully monitored and tracked. The county in Alameda County monitors these patients on a daily basis after they go home. Most of the times it used to be they would have to come by and make visits. Now they're FaceTime video visits, but they monitor them daily and they watch the patient take the medication. So they are that serious about compliance. And the patients are obviously educated why this is important. You know, they want to get better and they also don't want to infect friends or family. Next slide. So one of the things, as I alluded to, we do a lot of staff education because we need to work together as a team. And the more information our staff has, I think the better they're going to understand what we're doing and why. So education is provided to the new hires, new nurses, new graduate students. And Sam Avalon and her team also do it on an annual basis as well, updating people on what they need to do and why. We also do ongoing education as needed through our huddles, which is usually at the beginning of a shift, or one-on-one basis as needed if a bedside nurse is working with a particularly serious infection in a particular patient, so that they need one-on-one support to understand how they can best support the patient and reduce any possible spread of infection. We do educational materials, we do presentations, not so much flyers, it's all by internet now or posters, but we do some posters. The nurses will take this on as a project and they do make a big poster, and it's very colorful most of the time. We do a lot on our internet to educate the nurses. That makes it a little more user-friendly for them. We do, in years past, a patient safety blitz, educating our patients about what we're doing and why in terms of tuberculosis, hand washing, and what the particular bacteria mean to them if they're a patient. We have an employee health and safety fair annually. We also update Coven in terms of the SABA, which is the staff education monitoring that they do online. We included COVID-19 in that in the last couple of years. Infection prevention also presents updates for COVID-19. And we also have an internet video of how to properly don and doff your PPE. So if you have a question, you want to say, well, am I doing this right or not? We have it on video. Next slide. So future direction. We want to maintain compliance, obviously, with healthcare associated infections in line with the Centers for Medicare and Medicaid Services, but we want to see ourselves go beyond just the basics. And we want to make sure that our staff is educated, patients are educated, and as much information can be shared. So we do multidisciplinary infection prevention rounds that go through and talk on the nurses' stations. We also go to environmental services. We go to sterile processing. We go through the pharmacy, dietary, who's a huge part in making sure that things stay safe for our patients. We do quarterly discussions at the clinical evaluation committee, nursing oversight, and multidisciplinary infection prevention. I also try to go on a quarterly basis to medicine department, surgery department, and family medicine department. So we work with to prevent healthcare associated infections in our facility, trying to isolate the source of the infection, limiting transmission. And first and foremost, it's got to be hand hygiene, second hand hygiene, and third hand hygiene. So we want to sustain any of our initiatives. We want to mitigate, obviously, in terms of the COVID, any new variants. We're following along closely with the county, reporting back and forth. They have weekly meetings to update us on any of the new developments or any outreach that we might have to discuss with them. So we think we're fairly well prepared for further outbreaks, emergencies, and surge management. Obviously, we are all holding our breath, hoping that we are not going to see another one, but I feel we are well prepared. I mean, from administration down to environmental services and everybody in between, we educate as much as we possibly can. I think that's the last slide. Yes, thank you. I really appreciate the opportunity to bring this to you because I want you to know how hard your hospital team works, not only for you, you represent all of us, but also for our patients and our community. I mean, we represent a lot of people throughout our district, and just to let you know, we have a dynamic team that I'm privileged to work with. And I'll take questions.
Thank you very much, Dr. Martin and Mary, for that. You need an army to fight this invisible foe of infection, and we thank you for setting the bar high and keeping us informed. Any comments, questions from the board?
Just a great job.
Yeah.
Thank you. I always count on you to ask me a question.
Very good. Well, thank you very much for being here tonight and sharing with us.
Thank you, thank you, thank you. All right.
Good night.
I'm going to sign out, okay? But if there's questions that come up later, you can always know how to find me.
Very good.
Okay, bye.
Thank you. Wonderful. All right, let's move on with our finance report from Chris Henry, our VP and CFO.
Hey, thank you, Director Yee. Tonight we will be looking at the results of operations and the financial results for November. Moving into our acute inpatient statistics, our inpatient average daily census for the month came in higher than expected at 136.9. We'd expected 128.6, so that's an increase of about 6.5%. Our combined average daily census, which includes our outpatient observation days, these are outpatients that are actually occupying a bed, just as our inpatients are, came in 13.2 higher than we expected at 148.6. Admissions for the month came in just a little bit above budget at 740. We'd expected 734 for the month. Patient days for the month came in 249 higher than expectations at 4,107. Our outpatient observation equivalent days were 147 higher than we expected in the budget at 351. Our average length of stay for the month, pretty close to budget at 5.43. We'd expected 5.26. Moving in utilization, case mix index for the month came in lower than expected for the month at 1.495. Deliveries came in 5 above budget at 115. We had 48 more surgical cases than we expected at 380. Cath lab cases for the month were 7 below budget at 183. Outpatient visits were 277 or 3.8% higher than budget at 7,553. And our emergency room visits came in 602 higher than budget at 4,241. Looking at the details of the cath lab and the OR, really the variance in the OR largely driven by joint replacement cases that were 37 higher than budget at 166. We did expect for a number of our joint replacement cases to migrate to the Peninsula Surgery Center in October, but due to the delay in opening that, those cases are still being done here. Also in the OR, our other surgical cases were up by 15 at 180. Cardiac surgical cases right on budget for the month, and neurosurgical cases 4 below budget at 21. In the cath lab, a couple of drivers going on there. Cardiac cases and neurointerventional radiology combined to be below budget by about 14. That was offset by our peripheral vascular and non-vascular cases, which are combined 7 above budget. So that's how we ended up at 7 lower than budget at 183. Moving into productivity, of course, with all the activity in the house, you would expect our FTEs to be up. Productive FTEs for the month were about 6% higher than budget at 1,284.7. We had 220.4 non-productive FTEs for the month, giving us total FTEs that were 92.5 or 6.5% higher than budget at 1,505.1. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, however, came in lower than budget at 6.18. We had expected 7.15, so we were operating pretty lean, I think, during November. Moving into financials, and as always, we'll look at our Governmental Accounting Standards Board presentation first. This is the presentation we use for our audited financials. Total patient revenue for the month came in a little under 17 million higher than budget at 181,606,000. Contractuals came in slightly lower than budget. Really in both categories, our contractuals for Medicare and commercial payers came in at 75.51% versus 75.40. Our provision for bad debt and charity came in at 1.72% of gross revenue versus 1.88. Those combined coming in at 77.23% of gross revenue versus a budget of 77.28. Moving into our expenses, so that ended up with net operating revenue that was about 10.3% higher than budget, or 3.9 million at 41,691,000 dollars. Operating expenses came in a little over 1.7 million higher than budget at 39,999,000 dollars. About $1.6 million of that came from our salaries and wages with our higher FTEs. We did have lower health and welfare claims in the month by about 572,000. Supplies were higher, offsetting that by 427,000, and that came as a result of the higher joint cases and the implants that go on there. Our TAVRs were up for the month, and we used more neurostimulators for the month, largely driving supplies up. Pro fees for the month were up about $182,000, driven by higher consulting fees, and purchase services were $292,000 higher than budget, driven by a number of things. With our SNF bed reservations, we had some architectural fees related to the master plan, and some repairs and maintenance driving that number up. Marketing expenses for the month were $171,000 lower than budget, and it really rounds off all the offsetting that was going on. So we ended the month with operating income of just under $1.7 million, versus a budgeted loss of $429,000. Non-operating income for the month came in with a loss of $155,000. We did have a $116,000 unrealized loss on our investments for the month. And our rental income came in at $50,000 with a $50,000 loss for the month. We had a lot of maintenance going on in our rental properties, really driving that down. So we ended November from a GASB perspective with a total bottom line of a little bit over $1.5 million versus a budgeted $343,000 loss. Looking at our Financial Accounting Standards Board presentation, this represents some adjustments that the financial markets might make when they look at us. First thing they would do would be to reclassify the interest expense on our revenue bonds out of non-operating category up into our operating expenses to end up with operating expenses from a FASB standpoint that were $1,761,000 higher than budget at $40,575,000 in operating income from a FASB perspective of a little over $1.1 million. Non-operating income, then they would remove the GO bond interest that hits there of about $1.16 million, and the related property tax that supports the debt service on those bonds. And they would remove our unrealized loss on investments to come up with non-operating income from a FASB perspective of $253,000 and a total bottom line for November of a little under $1.4 million versus an expected loss of $628,000. Looking at our earnings before interest, taxes, depreciation, and amortization, this gives us an idea of how much cash and income the operating and non-operating activities of the hospital are providing to the organization. So the first thing we do is we take depreciation, which is a non-cash transaction, out of our operating expenses to calculate our EBITDA of $5.6 million against a budget of just under $3.5 million. We then look at our non-operating activities before our interest expense, and that ends up at about little under $1.6 million against a budgeted $1.8 million for the month, giving us a total in November of about $7.2 million to take care of our debt service, capital spending, and program development. So are there any questions on November? Okay, before we move on, I do want to mention that this week we did have our annual review on our revenue bonds from Moody's, and the committee rendered a decision yesterday to affirm our Baa2 bond rating. They did maintain the negative outlook. The ratings committee was encouraged by our significant turnaround here in the last quarter and the trailing months. They did note that they can see the strategy materializing that we've been articulating to them. They were encouraged by our increase in cash and our liquidity, and our strong community support is evidenced by our GO bond approval last fall. They remain concerned about the environment in general for all hospitals, with the instability related to COVID and the spikes such as what we're experiencing now, and their impact on continuing to improve liquidity and general operational performance. But overall, they were very encouraged. I think it was a very good outcome given the financial challenges we had last year. So things looking good from Moody's perspective.
Good.
All right, I will move on to present the preliminary December 2021 numbers. It was, again, another busy month, and really is, I think we all realized that towards the end of this month, we started to see our COVID numbers rise. And so they've been going up, and we'll continue to see that in January too. But it was a busy month for December. Beginning with gross revenue of $193.5 million for December was above budget by $21.6 million or 12.6%, and above December of 2020 by $10.1 million or 5.5%. Inpatient gross revenue of $108.8 million was below budget by $4.1 million or 3.6%, and 11.7% below December of 2020. Admissions and length of stay were higher than budget. However, the shift, again, as Chris has talked about in November, the shift in joint cases from inpatient to outpatient and the lower patient acuity in the month resulted in a lower inpatient revenues. Outpatient gross revenue of $84.7 million was above budget by $25.7 million or 43.5%, and basically 40.9% above December of 2020. I do want to note in December we had 35 COVID-19 discharges representing 4% of total discharges. This does represent, as I mentioned at the beginning, an increase from the prior 2 months, which averaged 23 COVID discharges. Moving on to our key census, average length of stay of 5.4 was above the budget of 5.22 by 0.18 or 3.4%, but lower than the December length of stay of 5.67 by 4.8%. Again, it's the shift in joints from inpatient to outpatient is increased, has increased the impact on the overall length of stay, because we had only 8 joint cases that were inpatient compared to 44 that were budgeted. In terms of outpatient observation days were 110 or 48.5% above budget at 337 days, and were 159 or 89.3% above December 2020. Our inpatient average daily census of 150.1 was above the budget of 134.6 by 15.5 or 11.5%, but was 18.2 or 10.8% below December of 2020. Combined average daily census of 161 was above the budget of 141.9 by 13.5%, but was 7.5% below of December 2020. In December, there were 5 discharges with length of stay greater than 30 days, ranging from 35 to 119 days. If we excluded those, our length of stay would be about 4.9. We do still have in-house a number of patients. We have 7 of them with long length of stay over 30 days, and they range basically from 56 up to 222 days. So we have 1 patient who's been here a significant amount of time. Moving on to our admissions. Admissions were above budget by 56 or 7%, largely driven by surgery and cath lab cases being above budget. Admissions for the month were 52 or 6.5% above December of 2020. Looking at patient days, our admissions were above budget by 7%, as I said, and length of stay, average length of stay was higher than budget by 3.4%. This resulted in our patient days of 4,654, which was above the budget by 482 or 11.6%. And patient days for the month were 10.8% below December of 2020. We had a good month in terms of our surgical trend. Our total surgeries in December of 397 were above budget by 58 or 17.1%. Surgeries were 65 or 19.6% above December of 2020. Inpatient surgeries were 21 or 13.3% below budget at 137 and 2.8% below December of 2020. But our outpatient surgeries were 79 or 43.6% above budget at 260 and 36.1% above December 2020. Again, it's this, we had budgeted for less outpatient joints because we had felt that they would be at that point migrating to the Peninsula Surgery Center. Looking at the breakdown of our surgical activity, joint replacement surgical cases were above budget by 62 or 52.5%, and were 43 or 31.4% above December of 2020. Our neurosurgical cases were above budget by 22.2%, and were 4.8% above December of 2020. Cardiac surgery cases were below budget by 33.3%, and were 16.7% below December of 2020. And all other surgical cases combined were below budget by 3 or 1.6%, that were 14.2% above December of 2020. Cath lab also had a busy month. Cath lab cases for December of 203 were 18% above budget and 2% above December of 2020. Cath lab inpatient cases for December of 95 were 11.8% above budget, but they were 3.1% below December of 2020. And our outpatient cases for December of 108 were 24.1% above budget and 6.9% above December of 2020. And looking at the breakdown, you can see cardiac cases were below budget by 6 or 7.2%, and 2.5% below December of 2020. Our non-vascular cases, or non-vascular interventional radiology cases were significantly above budget by 43 or 110.3%, and 9.3% above December of 2020. Peripheral vascular cases were below budget by 6 or 12.2%, and 2.1% above December 2020. Lastly, as you can see, neuro interventional radiology cases were on budget, and they were 2 below December of 2020. Our deliveries were for December at 137, which were below budget by 2 or 1.4%. Looking at December of 2020 last year, they were 28 or 25% above December of 2020. Non-ER outpatient trend, the outpatient visits of 7,284 were above budget by 45 visits or 0.6, and were above December of 2020 by 350 or 5%. This was primarily driven by our X-ray visits were above budget by 161 or 10.6%. Our cardiac rehab visits were above budget by 123 or 28.1%. But I do want to note that they are still below our pre-COVID-19 monthly average of 796. So it's slowly coming back. Our lymphedema clinic visits were above budget by 66 or 61.7%. And that was offset by our lab visits, which were below budget by 354 or 12.3%. Our emergency room visits, we had a very, very busy emergency room in December. We had 4,817, which were above budget by 926 or 23.8%, and 606 or 14.4% above the prior year. I know in December we hit some of the highest days that we'd had, and I think we even, though in January, got higher from that. But as we know, emergency room has been very busy. So looking at our gross revenue, our cath lab cases were above budget by 31 or 18%. However, due to the higher volume of lower acuity non-vascular cases, our cath lab revenue was down by $479,000 or 4%. Our deliveries were below budget by 1.4%, but there were a higher number of C-sections, which drove the birthing center revenue up by $129,000 or 3.4%. Our emergency room visits were above budget by 926 or 23.8%, and the acuity was higher, driving emergency room revenue up $2.8 million or 27.3%. Our patient days were above budget by 11.6%, 482. However, the ICU, which has a high revenue per day, was down 20.2%. And this resulted in room and board revenue higher than budgeted by only 8.7% or $2.9 million. Our total surgeries were higher than budget by 58 or 17.1%, and there were 62 more joint replacement cases than budgeted. And so this drove the surgical services revenue higher than budget by $7.5 million or 23.7%. And our outpatient activity drove ancillary services revenue above budget by $8.7 million or 10.8%. Looking at our preliminary payer mix, we can see that for the month of December, our government-sponsored patient revenue made up 70.2% of total gross revenue. This is lower than budget by 1.7% and lower than the prior year by 3%. HMO was 2.8% of gross revenue, which is slightly above budget of 2.7%, but lower than the prior year of 0.2% of gross revenue. PPO was 25.2% gross revenue, which is above budget of 23.4% and also higher than the prior year percentage of 3.1% of gross revenue. And private pay was 1.9% of gross revenue, which is below the budget of 2%, but higher than the prior year percentage of 0.2% of gross revenue. So I do, as you can see, we overall had a relatively very busy, well, I should say we had a very busy month. And looking at the preliminary net revenue without any other supplemental revenue is approximately $43 million compared to a budget of $39.3 million, which is a favorable variance of a little over about $3.7 million or 9% at this point. So again, you will see how busy we were. It's reflected in our productive FTEs. You can see they were above budget by 115.5 or 9.4% at 1,346.4. Our non-productive FTEs were below budget by 26.7, 11.6%, or at 203.3, which unfortunately, given the holidays, we just weren't able to, even though we had the holidays, we weren't able to get a lot of our staff out to take the holiday or take some time off, given how high our census was. So our total FTEs of 1,549.7 were above budget by 88.8 or 6.1%. But if you look at our productive FTE per AOB, 5.04, it was lower than the budget of 6.01 by 16.1% and lower than the prior year of 5.32 by 5.3%. So you can see we're operating in a pretty lean fashion in December. And then total FTEs for adjusted occupied bed of 5.81 were lower than budget of 7.13 by 18.5% and lower than the prior year of 6.17 by 5.8%. Then looking at our preliminary outpatient statistics, Whitmith clinic visits were above budget in December by 154 or 1% at 16,217. But they were 675 or 4% below December of 2020. We had a positive variance driven primarily through by pediatrics, and it was offset by some of the physicians taking time off during the holidays. Looking at our outpatient visits for Development Corporation came in at 2,130, which were below budget by 208 or 8.9% for the month of December. But 3.5% below the December of 2020 visits. Our outpatient, our rehab center was below budget by 194. I will say that we did just bring on 2 new physical therapists that started the second week of December and are ramping up. And we also brought in a new clinical director that just started this week. So I feel like we'll be up to sort of a full complementary of staff at the outpatient rehab center going forward. Our Washington Radiation Oncology Center treatments were down by 27, offset by our Washington Outpatient Surgery Center, which was above budget by 24. We saw a large increase in gastro cases of about 33. And then our Ohlone College Student Center was below budget by 11. And really what's happening there is that about 75% of the students are attending classes virtually. So it is impacting the Student Health Center and students coming into that. All right, looking at our key financial statistics, days cash on hand for December ended at 163 days, a decrease of 2 days from last month, but consistent with the prior year. I will say what's impacting that, we had 3 pay periods in December, which represents 8 days. We also had a intergovernmental transfer of 1.8 million, which represents about 1 day, for the hospital quality assurance fee, which we expect to receive close to 6 million in February or March. And this was cash outflows were partially offset by higher collections in the month. We also we do have a bond debt service for interest only of about 4.3 million. Represents about 4 days in January, so you'll also see that. In terms of our days of gross revenue and accounts receivable, they came in at 68. I will say that we did, even though there were a number of holidays in December, we did have patient cash collections of 47.6 million, which was the highest cash collections in the last 12 months. So that was good in terms of December. Looking at our charity care, there was a 1.4 million in charity care adjustment in the month of December. And really the majority, this includes one account that occurred in the beginning of 2021 that just was written off completely for an amount of 1.2 million. So that was the main driver of this amount of charity care. And this patient had a very long length of stay in our hospital and had previously exhausted their maximum lifetime days. All right, and then lastly, in terms of just looking at our summary of homeless patient activity, our fiscal year to date, December, there were 1,043 patient encounters representing 581 homeless patients, of which 164 had more than one encounter during the period. The total estimated unreimbursed cost for fiscal year to date was about 3.1 million. And that is my report for December of 2021. Are there any questions?
Good, thank you. Do you want to go ahead with announcements, Kimberly?
Yeah, why don't I go ahead and do announcements. I want to begin by talking about the Employee of the Month for January of 2022. He is an individual that is known to many people throughout the healthcare system. Yes, it's John Peterson. He's our transport coordinator. And for those, I think John is probably one of those employees that is known by almost everyone throughout the house. 45 years ago, John Peterson joined the staff of Washington Hospital as an orderly, working the night shift in the emergency department. His career has included working as a senior orthopedic technician and his current role as the coordinator of Central Transport and the lift team. John played a pivotal role in the creation of Central Transport, and when the Morris Hyman Critical Care Pavilion opened, John was instrumental in the safe transport of patients. On a daily basis, John instinctively seems to know when a patient needs an extra gentle approach, an additional blanket, or just a few kind words as he takes them to imaging or the cath lab. Maybe one of the reasons John has been successful working at Washington Hospital for so many years is that he truly embraces the patient-first ethic. John believes that if you can help one patient have a better day, it's good for the patient and for the staff member. Quote, "I feel like my coworkers and our leadership team are all driving in the same direction. We want to serve our community and keep each other safe," end of quote. John's colleagues are quick to praise his commitment to safety and his ability to de-escalate a potentially challenging situation. Even during a code burst, one coworker notes, John has the ability to read the room and act in a swift and quiet way to resolve the conflict. When not at the hospital, John and Kim, his wife of 41 years, spend time with their 2 rescue dogs. So we're very excited to present to John Employee of the Month for January of 2022. And then I just have a few other quick community outreach announcements. I do want to say during the month of December, we continued with our vaccination clinic. As of January 7th, a total of 81,929 COVID vaccine doses have been administered to community members at our vaccination clinic. This represents all first and second doses as well as third booster doses. On November 3rd, we began vaccinating children ages 5 to 11 years old. As of Friday, January 7th, a total of 2,417 vaccinations have been administered to this age group. And as of January 6th, we started offering boosters to ages 12 and up. In terms of our education, on Tuesday, December 14th at 3:30 p.m., Dr. Michael Golden presented Get Fit at Home the Right Way, Strengthen Muscles While Protecting Your Joints on Facebook Live and YouTube. 112 community members participated in the live event, and since that time, 530 additional people accessed the presentation on one of our social media channels. On February 8th, an upcoming event at 6:30 p.m., Dr. Rohit Sehgal, our cardiologist with Washington Township Medical Foundation, will present heart attack symptoms and prevention on Facebook Live and YouTube. I do want to just say in terms of Washington Hospital Healthcare Foundation, entering into 2022, the foundation is working to expand the Honor a Caregiver and Plan Giving programs by creating new ways to engage donors and staff through seminars, personalized donor updates, and exclusive events and more. Then lastly, in terms of the holidays and some donations that were made as part of the Washington Hospital Management Staff Holiday Celebration, members of the management staff donated $6,700 to the Tri-City Food Bank. Then we also had the Washington Hospital Employee Association held a coat drive and blanket drive to benefit Viola Blythe Center in Newark. And our employees donated 5 barrels of blankets, jackets, and socks. And we also held a gift card drive for City of Fremont's Giving of Hope, and 255 gift cards were collected by employees. And lastly, we had donated $5,000 to the City of Fremont's Afghan Refugee Relief Funds. So those are my announcements that I have for this evening.
Thank you. Great news. Great news. Great. Well, let's go ahead and tackle the action item. Do you want to continue on, Kimberly, and introduce this?
Yes, I would like to do that. We have 2 action items, 2 resolutions this evening, and they are regarding our employee. Yeah, Mr. Wallace, do you want to?
Yes, I'm going to leave the meeting, so I will see you in the next meeting.
Thank you.
All right. Thank you. All right, so we have 2 resolutions this evening, and recently we changed our third-party administrator for medical employee benefits, the carrier from Blue Shield, to Health Comp effective January 1st, 2022. And as required by the agreement, the district is required to open a new bank account designated for the payment of employee benefit claims. The processing of claims out of this account will be done by Health Comp on behalf of the district. And so, as mentioned, there are 2 resolutions. The first is a banking resolution, and this resolution authorizes myself, Kimberly Hartz, Chris Henry, and Mr. Ed Fayen to open and maintain a bank account at Fremont Bank for Washington Township Healthcare District employee benefits. And the signature card is attached for your reference. The second is a resolution for Treasury Management Services Agreement Acceptance, and this resolution authorizes myself, Kimberly Hartz, Chris Henry, or Ed Fayen to activate banking services and enter into the services agreement. The Treasury Management Services acceptance agreement is attached to the resolution for your reference. And Paul, do you want to make the comment?
I want the record to reflect that Director Wallace is recusing himself from this item because he is chairman of Fremont Bank.
Thank you, Paul. Yep.
Recusing himself.
Okay, very good. All right, may have a motion for the first resolution, 1, 2, 3, 4.
Yes, this is item A, resolution 1234, banking resolution. Madam President, in accordance with district law, policies and procedures, I move that the board approve resolution number 1234 to authorize the CEO, CFO, and COO to open and maintain the accounts contemplated on Fremont Bank's signature card and deposit account agreement and disclosure as delineated in this resolution.
Thank you. May I have a second?
Second.
Thank you, Director Stewart. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace, Director Epen,
Aye.
Director Nicholson.
Aye.
Very good. That motion passes. Thank you. The next resolution.
Okay, item B, resolution number 1235, Treasury Management Services Agreement. As a point of clarification, as I read this motion, the term "the company" actually refers to Washington Township Healthcare District, so as to avoid any confusion.
Thank you.
Madam President, in accordance with district law, policies and procedures, I move that the board approve resolution number 1235. A, the company finds that it is in the best interest of the company to enter into the TMSA as amended from time to time. B, the company authorizes and appoints each of the officers of the company and any authorized signer on the accounts, acting individually or together, to execute and deliver the TMSA. C, if any one or more of the foregoing persons are authorized to negotiate terms and conditions of the acceptance, amendments, or supplements to the acceptance, and to enter into such other agreements, supplements, and amendments as they individually or jointly determine to be appropriate, including amendments or supplements. And D, the authority given above will continue, and the bank may rely on the actions of any person referred to above until such time as the bank is given formal written notice of the revocation of such authority, and the bank has an opportunity to respond to the same. All acts and deeds taken by any person referred to above shall be deemed the act and deed of the company for all purposes relating to the acceptance and to all services described in the acceptance or provided by the bank to the company under the acceptance.
Very good. Thank you, Dr. Nicholson. Do I have a second?
Second.
Thank you, Dr. Stewart. Okay, Dee, a roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace, Director Epen,
Aye.
Director Nicholson.
Aye.
Very good. So that motion passes. Thank you very much. So we will now go into closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow, and she'll be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable action taken So thank you very much. We will now adjourn to a closed session.